All right, good morning, everyone. Before we begin today, we'd like to remind you all that this event is being recorded. And we also ask that everyone please turn your mics off. And except for when you're presenting or in the breakout room, we are asking that you turn your cameras off just to help with bandwidth consumption. So we're going to get started. So welcome to Pitch Your Project, a MIRA Trainee Network event. As we begin, we'd like to take a moment for land acknowledgements. McMaster University recognizes and acknowledges that it is located on the traditional territories of the Mississauga and the Haudenosaunee nations, and within the lands protected by the Dish with One Spoon, Wampum Agreement. Thank you. Today, we have 20 exciting presentations for you from trainees across McMaster. This event is following a 3-minute thesis-style presentation format. What this means is our presenters have one slide with no animations, and we'll talk to you about their research for 3 minutes. If presenters have not already finished, at the 3-minute mark, they will be interrupted. Now, there is no designated question or answer period, but if you do have a question, we do encourage you to use the chat to privately message that presenter. Below is our schedule for today. Our presenters have been divided into categories based on their current level of education. So today we have undergraduate students, master's level students, PhD students or candidates, and postdoctoral fellows presenting. There are 2 different prizes that presenters could potentially win today, and those will actually be decided by you. So we have best overall presentation for their category, as well as best over slide. Throughout today's event, you will see a link pop up in the chat where you can go to fill out a form for each category. We do ask that you use one form. It has multiple questions for each category. You can have it open the whole time and fill it out as you go. Just don't click submit till you're finished. Halfway through today's presentations, we will divide everyone into breakout rooms. Each room will hopefully have a MIRA representative, whether that be a trainee exec or a staff member. This is an opportunity for everyone, not just the presenters, to share a little bit about your work and talk to fellow researchers. So again, we do ask that you mute your mics and turn off your cameras unless you're presenting or in the breakout room to help us with bandwidth consumption. Without further ado, we are going to get started into our presentations. So today we're starting with our undergraduate category. And leading the way, we have Kevin Day and his research looking at macrophage senescence and healthy aging. So Kevin, when you're ready.
Since antiquity, we have dreamt of an elixir of immortality, although you must be asleep to believe in it. I offer you no such elixir, but rather the next best solution. In my research, I study the aging process so that we can all age in a healthy manner. Recently, my lab has conducted a seroprevalence study on COVID-19 as a diagnostic tool, in which a gentleman tested positive for COVID-19 but showed no symptoms. I believe he was asymptomatic because he had a lower age-associated chronic low-grade inflammation known as inflammaging. Now, inflammaging is quite a complex topic, so let me entertain you with a thought experiment to explain it. Imagine you're in a room, and as time goes on, there is an accumulation of garbage or these senescent cells. Luckily for you, you also have these blind garbage cleaners, these macrophages, but they have to rely on the stench of the garbage to locate it and dispose of it. And the stench in immunological terms is really these pro-inflammatory factors that these senescent cells secrete to attract macrophages. And if these senescent cells don't get removed, then these pro-inflammatory factors will contribute to inflammaging. Now, sometimes the stench gets so stinky that the garbage cleaners or these macrophages say, you know what? I give up. I can't do this anymore. But Furthermore, I'm going to become garbage too and further stink your room. And you could imagine this discomfort you have. And the same thing is what your body is experiencing with all this inflammation going on. And as a result, diseases that should have little to no impact as we age have a far more impact. So this gentleman that tested positive for COVID, but was asymptomatic, must have a clean room and a healthy cleaning crew. And I particularly study the interaction between senescent cells and macrophages and why these macrophages take on a senescent-like trait. We have a very creative name for these macrophages, in fact. They're called senescent macrophages. And hopefully, by therapeutically targeting these macrophages through my research and others, we can delay age-related diseases as a group, as a clean room is a prophylactic measure against many problems. So I ask you to take a leap of faith, yes? Believe not in a charlatan selling you anti-aging cream. Believe in aging research on senescence so we can all be young men and women together. Thank you.
Thank you, Kevin. Our next undergraduate presenter is Kate Zhao, and she'll be discussing her work on a novel in vitro assay to study molecular mode of action of potential anti-Alzheimer's drug candidates. All right, Kate, when you're ready.
Augusta Ada was the first person to be diagnosed with Alzheimer's disease. During her era, people did not understand the disease and offered her no treatment. The unfortunate news is that more than 100 years later, we still don't understand the disease and still don't have a solution. Alzheimer's disease has a devastating impact on the patients and their families. Gradually, the patient's personalities and memories fade away. For families and friends, it is a slow death, and day by day, their loved ones leave them. More than 30 million people are affected by this disease, and there are nearly 10 million new cases every year. It is also a huge burden on our healthcare system and economy. Hello, everyone. My name is Kate, and I'm honored to present my thesis project. While there are huge gaps in our knowledge, what we do know is that a protein called amyloid is one of the hallmarks of Alzheimer's disease. These amyloid peptides can aggregate together and form plaques that are resistant to proteolytic degradation. These plaques can initiate a chain of reactions in the brain and ultimately lead to neuronal injuries. The goal of my project is to evaluate the mechanism of two potential treatments, homotaurin and curcumin, and determine their impact on amyloid aggregation. Both homotaurin and curcumin are small molecules that have shown promising effects in previous research. Homotaurin binds to the peptides directly, thus people expected to inhibit abnormal protein aggregation. Homotaurin received a lot of attention several years ago as an anti-Alzheimer's drug. However, it failed to reach its clinical outcomes in phase 3 studies. Interestingly, based on our experiments, homotaurin actually resulted in more plaques. The second type of small molecules, such as curcumin, act on the membrane instead of binding the peptides. And we found that by changing membrane fluidity and thickness, thus removing the mismatch between peptides and membranes, curcumin significantly reduced amyloid aggregation. In conclusion, we propose that small molecules targeting the membrane are a promising new approach to inhibit amyloid plaques. Last but not least, I would like to thank the Ryan Steelers Lab for everyone's help and MIRA for the research funding from last year.
Thank you, Kate. So at this time, those are our undergraduate presenters. So if you do have your voting form up, you can answer that question if you would like. So we're now moving on to our master's level presenters. Leading the way, we have Julia Coletta and her work on improving physical activity and mobility during a pandemic via live online exercise sessions for older persons, a pilot RCT. Whenever you're ready, Julia.
As the COVID-19 pandemic persists, the fight against sarcopenia prevails. Today, I will pitch to you a way in which older adults can beat the fight against sarcopenia. Now, what is sarcopenia? It is a loss of muscle and function as we age. It can contribute to a variety of negative health outcomes, including an increased risk for falls and fractures, type 2 diabetes, and it can decrease individuals' mobility and independence. It has even been shown that a relative reduction in daily steps can result in significant reductions in muscle mass, strength, and possibly an increase in disease risk. Unfortunately, we see an increased risk of sarcopenia in sedentary older adults, and with the current COVID-19 pandemic, it has become more difficult to maintain an active lifestyle. We currently know little about the indirect consequences of the pandemic for older adults, but older people appear to be at a higher risk of several secondary complications and long-term negative health outcomes. These complications include declines in physical health and mobility, social isolation, and worsening mental health. Now you may ask, how do we mitigate these negative consequences? And the best answer I can give you is exercise. Exercise plays a key role in mitigating many negative health conditions as it alleviates strength, mobility, and cognitive declines, and reduces anxiety and depression. It has been shown to reduce social isolation and loneliness, which are more apparent during the pandemic as individuals are more often finding themselves at home and alone. Exercise can also prolong functional capacity and independence in older adults, allowing individuals to be more mobile and participate in the regular activities of daily living for longer. That being said, we are looking for a safe way for older adults to continue to participate in physical activity with some form of social connectivity while still following the public health guidelines. Implementing new technologies based on online resources may help to reduce declines in older adults' health. Therefore, we are proposing an online, real-time group exercise program on Zoom tailored to the needs of older adults. The program will occur 3 times a week over 8 weeks with a focus on strength, aerobics, and balance, and will be delivered by registered kinesiologists and physiotherapists. We anticipate that the physical activity program will alleviate the inactivity-related risk of declines in strength and mobility. We expect an increase in 7-day steps and activity-related energy expenditure, as we will actively encourage engagement in physical activity outside of the program. We also hypothesize that participants will demonstrate lower anxiety, depression, and loneliness following the intervention. We are aiming to improve older adults' levels of physical activity and mental health by bringing age-appropriate and ability-modified low-risk exercise programming to older people at a distance. Are you going to join the fight?
Thank you, Julia. Our next presenter is Rebecca Coher, and her work looking at the association between care of the elderly certificates of added competency among family physicians, practice patterns, and health service outcomes in the primary care setting. Whenever you're ready, Rebecca.
Great, thanks. Some of us may have grown up with a grandparent or can picture an older neighbor who lived next door. Keep this person in mind. As people age, they may experience changes in their bodies or be exposed to factors that increase their use of health services. In the wintertime, we might hear about an older person who has slipped and fallen and was rushed to the emergency department. Or you might know an older person who has been prescribed so many medications that they're unsure what medication alleviates what problem. Think again about the important older adults in your life, a grandparent, an aunt, uncle, neighbor, friend. How can we redesign the health system and educate healthcare providers about the unique needs of older adults? Hi, my name is Rebecca, and I'm a second-year graduate student in health research methodology. I'm interested in using big data to inform how we care for older adults in primary care settings. Have you heard of big data before? When we seek healthcare services, such as for a specialist referral or as part of a routine physical assessment, we are generating data. Healthcare providers collect data about you, the patient, when they care for you. You might have had your blood taken before, perhaps a urine sample, or maybe a mental health assessment. Regardless, all this information is securely and privately stored in provincial health databases. For my research, I will examine data about family doctors with specialized training to care for older patients. In Canada, family doctors can pursue an additional year of residency training to become more knowledgeable about a particular medical specialty or a patient population. My research involves creating a cohort or a group of family doctors with care of the elderly certificates. This study is the first population-level analysis to examine the practice patterns of care of the elderly family doctors in Ontario and the health services outcomes of their patients. In fact, it will be the first to build a validated cohort of family doctors with any additional training in data sets at ICES. ICES is a nonprofit corporation that allows researchers to study data that is collected during routine, publicly funded healthcare encounters. This study may inform how we train doctors to meet the needs of Canada's aging population. After I examine care of the elderly family doctors, this may open doors to evaluate other family medicine certifications or to examine this data nationally. In summary, we all recognize that our population is aging. We understand that older adults are more vulnerable to health complications and increased health service use. I hope that my research will inform medical education and primary care policies about how we train doctors to care for the most vulnerable members of our society, ultimately, so we can better promote their health and their safety.
Thank you very much, Rebecca. MIRA McCann is our next presenter in the master's level category, and she'll be discussing her work on addressing undernutrition in older adults using e-learning technology.
Good
When you're ready,
morning.
Mira.
Oh, sorry.
Go ahead.
Good morning, everyone. My name is MIRA, pun not intended, and today I will be presenting my thesis topic, addressing undernutrition in older adults using e-learning technology. So to start us off for today, I actually wanted to do a bit of a reflective activity. I want you to stop and think about, what did you eat for breakfast today? While thinking about this, here are some things to consider. Where did you buy this food from? Did you have to carry this food home, perhaps from a grocery store before you ate it? Did you have to store the food somewhere before you had it? Did you prepare this food? Was the food you ate soft or hard to chew? I ask these questions because I want to demonstrate that there are so many areas in which challenges can arise for older adults when having a simple meal to eat like breakfast. Perhaps the groceries were too heavy to carry home. Maybe the food was stored on the tallest shelf in the kitchen, and so forth. These issues can add up. With estimates that by 2031, older adults will be 25% of the Canadian population, it is imperative for researchers to focus on ways to increase the number of healthy years of life for this age group. For my thesis project, I want to challenge and go beyond the literature to identify the barriers older adults face in achieving adequate nutritional status by using secondary data from the Canadian Longitudinal Study on Aging. I want to analyze relationships regarding nutritional risks beyond low income, poor health, and social isolation, and instead focus on understudied areas such as neighborhood deprivation, immigration, cultural identity, and mobility. Knowing this information could be valuable when targeting high-risk groups and when providing guidance for public health policy to increase adequate nutrition. In summary, through my thesis project, I hope to increase knowledge about nutrition in healthy aging for older adults to influence public policy. Even though I won't likely have time to do the last part of my project, I hope to also one day create a co-designed e-learning tool that help address these nutritional challenges. That being said, thank you so much for taking the time to watch my short presentation.
Thank you so much, Mira. Amazing job at keeping going through that. Thank you so much.
Thank you.
Okay, our next presenter is Zaryan Masood, and his project is looking at tracking real-world changes in osteoarthritic gait patterns using wearable sensors. Whenever you're ready, Zaryan.
Imagine waking up in pain every day and dreading just standing up. Imagine flare-ups and stiffness and slowly changing your lifestyle so you don't have to walk or move as much. Imagine suffering through constant pain and stiffness and knowing there's no cure or direct treatment. This is the reality for roughly 5 million Canadians who have osteoarthritis. Hi everyone, I'm Zaryan Masood, a master's student in the Department of Kinesiology, and I am passionate about biomechanics, gait analysis, wearable sensors, and their application in healthy aging and osteoarthritis. Osteoarthritis, or OA, is a degenerative joint disease characterized by the loss of cartilage and change in bone, resulting in pain, disability, and a reduced quality of life. Gait analysis provides a non-invasive approach to study the mechanical environment of the lower limbs. This information is useful in not only understanding healthy aging, but the etiology and progression of common musculoskeletal disorders that accompany older age, such as OA. Conventional gait analysis systems are expensive and confined to a lab setting. Wearable sensors have revitalized gait analysis by making gait assessments more affordable and more accessible by being able to track real-world out-of-lab motion. Unfortunately, there's limited gait analysis research using wearable sensors in out-of-lab conditions, especially in osteoarthritic populations. However, from this limited research, we know that gait patterns are more variable in out-of-lab conditions, and a single collection is not enough to define one's normal, stable gait pattern. Therefore, the overarching goal of my research is to examine the day-to-day fluctuations in the out-of-lab gait patterns of older adults with NEOA and measure these meaningful changes in gait patterns through a dual-task perturbation. My project specifically will use wearable sensors strapped to the shank, as seen on the slide, to older adults with NEOA. Using these sensors, we will track the gait of our participants for a total of 5 times in order to understand their typical out-of-lab gait pattern. In doing so, we can pull numerous variables just from one stride, and by the end of our collections, we can have over 300 data points per variable for each walk. Using some machine learning, we can actually create patterns for your typical walk, as seen on the graph on the slide. This machine learning technique is analogous to a bank and credit card system. You have a normal or average spending pattern, just like you have a normal or average walking pattern as shown in the blue circle. If you spend in and around your average, that's expected, like in the green dot shown. Or if you walk as expected or you walk like you normally do, that's like the green dots shown. However, if something is abnormal in your gait or spending, the bank or we can detect this right away as depicted by the red squares. So why does this detection of uncharacteristic walking even matter? By using this method, we can better understand meaningful changes in gait and understand the day-to-day fluctuations. Also, we can further progress out-of-lab gait analyses, and most importantly, we can support future technologies that can allow health professionals to monitor a patient's gait and notify them of any clinically significant change to help them create a more holistic plan of treatment. By being able to track gait using wearable sensors, we hope to get individuals with OA back on their feet and to be their old selves and be excited to move again. Thank you.
Ooh, thank you. Our next presenter is Michelle May. Her work is looking at a secondary analysis of shared risk factors affecting osteoarthritis, cardiovascular disease, aging, and mobility. Whenever you're ready, Michelle.
Psychics. We've all heard what they do. They make predictions. Predictions about your life, your future. But what if I told you that you and I, we can make better predictions? Predictions about things that are important to you. Predictions about your health. But our predictions will be stemming from science and rooted in technology. My name is Michelle May, and I'm working with Dr. Bara Al-Khazraji in the Department of Kinesiology, and we want to predict your future. Calculators output the relationship between numbers. Graphs can plot and show us these relationships. But what we want to do is go a little bit further. We are looking to employ machine learning algorithms to determine relationships between tens to potentially hundreds of variables. How many of us know someone with osteoarthritis? What if I told you that the leading cause of mortality in individuals who have osteoarthritis is not actually joint related? It's cardiovascular disease. They share an interesting overlap of potential risk factors that may play a role in the progression of these comorbid conditions. Inflammation, functional status, and other common physiological mechanisms may contribute to these diseases of aging. Our goal is to identify these multivariate relationships between these risk factors. We will be analyzing the data collected by the Canadian Longitudinal Study on Aging. This will allow us to not only look at potential risk factors cross-sectionally, but also longitudinally, which may help us understand how these factors interact and morph over time. We will be using hierarchical clustering through machine learning approaches to seek out overlapping variables and risk factors underlying these age-associated diseases. Ultimately, we hope that by generating these risk profiles, it will help to develop strategies that aid in managing the onset and progression of these conditions that will ultimately affect the mobility, independence, and subsequently the quality of life in the aging population. So now, you've heard what I'm attempting to do. Like a psychic, I am going to try to make predictions about the future. Thank you.
Thank you, Michelle. Our last presenter in the master's level category today is Ethan Sampson, and his work on voxel-wise fractal analysis of functional magnetic resonance imaging, data for a novel method of early diagnosis for Alzheimer's disease. And when you're ready, Ethan.
All right, hello everybody. Today I'm going to be talking to you about my master's research, which is a bit of a mouthful, so I won't repeat again. But I will say it's not as complicated as it sounds, despite the fact that I'm working with complexity. And it is also, I will say, preliminary work, as recent circumstances have sort of inhibited our research. But I will say that we have seen enough to confirm that the algorithms are working, and it is suited to be a diagnostic tool, which will be used in my PhD thesis that I hope to present next year. So let's get into it. So we have talked a little bit about what Alzheimer's disease is. One of the previous presenters went into the physiological characteristics, such as the beta amyloid plaques, which I will talk about a bit. But what I'm more interested in right now is how Alzheimer's disease is diagnosed. So we can see on the left, there are two main categories of diagnosis that are typically used. So the first one, questionnaires, are the most common. It's a questionnaire, so there's no radiation as there is in PET. But as we can sort of guess, the main ones, the MMSE, the mini mental state exam, are really lacking in sensitivity and specificity. So it is just a series of questions that the patient will answer to the best of their abilities. And if they score a certain score that is below what's expected, they're diagnosed as having a mild cognitive impairment or potentially Alzheimer's disease. But this doesn't really get into, like, there are other forms of dementia. So the specificity saying it's Alzheimer's is pretty low. Next, there's nuclear medicine, or PET, positron emission tomography. So this is primarily based on imaging those beta amyloid plaques that were mentioned before, which is a hallmark of Alzheimer's disease. So we can see that in the Alzheimer's disease brain, there's a lot of areas lighting up, indicating that there's a lot of these plaques, and this person is suffering from Alzheimer's disease, which you can see also confirmed in the clock test drawn below. So where my research comes in is I'm looking at MRI methods, which involve no radiation and literally involve the patient just sitting in the MRI and having their brain function. So what we're doing is we're looking at the biologically based time varying signals that are generated in the fMRI, which can be classified as statistical fractals. And what we're doing is we're analyzing these fractals to see which areas are losing their complexity or their fractal dimension. So previous work done by our group has shown that there's a reduced time domain complexity in Alzheimer's disease. So the central hypothesis of my work is that AD characteristically impacts particular regions of the brain, creating a unique complexity signature, which is evident in the frequency domain variance in the fractal dimension. So while there's further post-processing needed to statistically confirm this, I will say that the algorithm is able to successfully map spatial variations in the fractal dimension and is able to generate clear differences in the healthy control brains in the Alzheimer's disease subjects.
Thank you, Ethan. That's time. Our last two presenters before our break are both in the PhD presenter category. So again, if you are filling out your voting form, please go ahead for our master's level presenters. Our first PhD presenter today is Arman Shakari, and his work looking at investigating the role of oxidative stress on neurotrophin transport in basal forebrain neurons. Whenever you are ready, Arman.
Thank you. So my lab studies the basal forebrain, an area you see in the top left there. These neurons are critical for learning and memory, and they're the first neurons to degenerate in Alzheimer's disease, and nobody really knows why. That's what our lab looks at. One clue we can get as to maybe why is that these neurons are very needy. They don't make their own neurotrophins, proteins needed for proper neuronal functions. Most neurons make their own. These neurons don't. Instead, they rely on their targets in the cortex and the hippocampus to make these neurotrophins for them. These have to then get sent back to the basal forebrain via retrograde axonal transport. This transport process is what we study in our lab. Look at the transport of one specific neurotrophin, pro-NGF, or pro-nerve growth factor. In Alzheimer's disease, we know that the transport of pro-NGF is reduced, as well as one of the pro-NGF receptors, TrkA, is also reduced. But nobody really knows why this happens, and that's what our lab is trying to figure out. We look to see if oxidative stress, one of the long-standing mediators of general Alzheimer's pathogenesis, is behind this TrkA reduction and eventual transport loss. And this makes sense when you look at how TrkA is trafficked in neurons, which is the image in the top right. It's a pretty busy picture. We're just focused on this one enzyme in the cell body, PTP, or protein tyrosine phosphatase 1B. This phosphatase dephosphorylates TrkA. And when it does this, the TrkA is free to go out and go to the axon and do its job. When this doesn't happen, TrkA stays phosphorylated and gets destroyed. PTP1B is an oxidation-sensitive enzyme, meaning when it's oxidized, it can't do its job. And it might be that in Alzheimer's disease, where we have high oxidative load, this enzyme can't do its job, TrkA stays phosphorylated, gets destroyed, and can't go out to axons. And my project involves probing this pathway. To do this, we use microfluidic culture of basal forebrain neurons to look at this. What microfluidic chambers do, it's the picture right underneath here. They separate out neuronal cell bodies and axons, and also linearize their axons to be able to parse out what retrograde and anterograde transport looks like. By separating out neuronal cell bodies and axons, we can actually manipulate them individually. So we can induce oxidative stress only in the cell body. We can knock out or knock down PTP1B by siRNA or pharmacological inhibition only in cell bodies, and then go look at axonal transport of neurotrophins. And that level of control that we have, that cell compartment specific level of control, is very important for us when we're going and trying to parse out this mechanism that takes place across the entire length of a very long cell type like a neuron. And in essence, that's what we do. We try to look at to see, does PTP1B and oxidative stress play a role in TrkA loss and ultimately the degeneration of basal forebrain neurons? Thank you.
Thank you very much. Our next presenter is Ken Nguyen, and his work on fall prevention and people with COPD. When you're ready, Ken.
A single breath can tell you a story. Sighing in relief, yawning in boredom, gasping in surprise. Inhale the future and exhale the past. But what about gasping for air, running out of breath, or fighting to breathe? To someone with chronic obstructive pulmonary disease, or COPD, the latter statements are all too familiar. COPD is one of the most common chronic diseases worldwide, affecting over 170 million people and accounting for over 3 million deaths per year. The problems faced by those with COPD don't just stop there. According to a prospective study tracking falls for 1 year, people with COPD fall 3 times more often than the average older adult. Additionally, COPD emerged as the strongest predictor for falling among 13 chronic diseases, including cardiovascular disease, arthritis, and depression. My name is Ken Nguyen, and I'm going to tell you about my work and my lab's work to tackle this problem, and specifically address my thesis on the use of balanced screening tools to assess for fall risk in people with COPD. Difficulties with maintaining balance strongly predict falls in the general older adult population, and my lab has shown that people with COPD experience greater difficulties with maintaining balance than the average older adult, with notable difficulties in movements such as sitting down in a chair, walking, and regaining balance after tripping. Current clinical practice guidelines for fall prevention do not include any specific balance screening tools to assess fall risk in people with COPD, leaving practitioners guessing which tests may be suitable to protect the patient. My lab has established 2 promising balance screening tools for identifying people with COPD with previous fall: the Brief BEST test, or the Brief Balance Evaluation Systems test, which screens for the performance of all 6 theoretical balance systems, and the single leg stance test, which tests the duration that an individual can maintain balance while standing on one leg. Which brings me to my project. I want to test whether these balance screening tools, among others, can predict the occurrence of a fall over 1 year in people with COPD. Our goal is to inform future practice and provide the most accurate balance and screening tool to identify the fall risk in people with COPD. That way, we can intervene before the occurrence of a fall so that those with COPD can live their lives with one less thing to worry about. Thank you.
Thank you, Ken. All right, so we are now going to move into our breakout rooms, which is a time where you can actually talk a little bit about your research. So we're planning to everyone go in an online circle and share your research. You should see a window pop up shortly that'll take you to your designated breakout room, and we will call you back after 10 minutes. At this time, we do encourage that you use your cameras and talk to everyone, both virtually and visually.
Okay, so I'm going to go ahead, Cassandra, and open the breakout rooms. So you should all have the option to join your breakout rooms now. Hi, Julie. Did you
Hi.
happen
I'm
to
not sure what
disconnect?
happened. Yeah, my computer just shut down.
Okay, sounds good. I will assign you to a breakout room, okay?
Yeah, thank you. I was in 4 last time.
Okay, perfect. Thank you.
Thanks.
So you should have the option now.
Yeah, perfect.
Hi, Farzad. Can you hear me? Hi, Kara. Can you hear me? So for those of you that have entered for the MIRA 3MT event, it's currently going on. Folks are just in their breakout rooms right now, just chatting about some research. So the breakout rooms will actually be over in 1 minute. So I'll just get you all to stick around here, and then we'll resume the remainder of the presentations.
Is that the right screen, everyone?
Yep, perfect.
Awesome. Okay. So welcome back from the break. Thank you all for staying with us. Hopefully everyone got out. I know sometimes people leave Zoom by accident instead of coming back to the main room. So hopefully we are all still here. So we're going to continue on with our presentations. We still have presenters in our PhD category. So if you're voting, hold off on that. Our next presenter is Vanessa de Robes, and she's looking at the understanding of adversity and obesity through the life course. Sorry, Vanessa, give me 1 second. Okay, when you're ready.
Have you ever considered that events that happened to you during your childhood could influence your health years later when you're an older adult? Looking back at an individual's life experiences may help to better understand patterns of health and disease that we see in older adults. These events that occur at different periods of life may accumulate over time, which may increase the risk of certain diseases. Those who have a greater accumulation of risks throughout their life may experience worse health outcomes in later life. With the aging population, it is becoming more important to understand how various exposures throughout the life course play a role in healthy aging and how they may alter the development of chronic diseases in older adulthood. My name is Vanessa de Robes, and I'm a second-year student in the PhD in Health Research Methodology program at McMaster University. For my thesis, I'll be exploring adversity throughout the life course and obesity in older adulthood. In Canada, 32% of adults have reported experiences of adversity during childhood. This includes physical, emotional, or sexual abuse. It is well established that early life adversity has a profound impact on health throughout the life course and is strongly associated with an increased risk of many chronic diseases in adulthood, including obesity. However, the mechanistic pathways are not well understood. It is thought that the pathway of obesity development may be explained through nutritional patterns or accumulated stress. In addition, the current COVID-19 pandemic is another example of extreme adversity that is currently impacting individuals across the globe. Public health pandemic mitigation strategies such as physical distancing have led to increased stress and altered nutritional patterns in a rapid period. It is not yet known if this sudden period of adversity resulting from COVID-19 has impacted rates of obesity. The objectives of my thesis project are first to understand the associations between early life adversity and obesity in older adulthood, and adversity as a result of the COVID-19 pandemic on obesity. The next objective is to understand what the mediators of these associations are. To address all objectives, I will be using data from the Canadian Longitudinal Study on Aging. The CLSA is a nationally representative sample that contains data on over 50,000 Canadians aged 45 and older. This data set is unique as it has collected comprehensive obesity measures, including measured and self-reported body weight, waist circumference, and body fat percentage. Understanding risk factors for obesity is crucial, as almost 27% of Canadians have obesity. Obesity is not only a disease, but is also a risk factor for many other chronic diseases. Identifying older adults who may have had increased adversity throughout the life course will allow for modifications to be made, contributing to healthy aging and lowering the risk of chronic diseases. Thank you.
Thank you, Vanessa. Kelsey Harvey is our next presenter, and she'll be discussing her work on exercise instruction for older adults, embodied education, and inclusive-exclusive physical cultures. Whenever you're ready, Kelsey.
Thank you. Have you ever attended a group exercise class and walked out thinking, that was the best class ever? What else does this instructor teach? Or worse, terrible, I will never go to that class again. These experiences show us that group exercise instructors play an important role in how much we enjoy a particular exercise class, which influences our intentions to return. My research sought to understand this relationship between exercise instruction and the experiences of older exercisers. Hi, my name is Kelsey, and I'm presenting the results of my PhD thesis. Instructors who work with older people not only need to know how to safely and effectively teach the physical movements comprising the exercise routine, but must also understand the process of aging. Instructors who work with the general public, classes where adults of all ages, including older adults, these instructors are trained to work with young, healthy bodies and know very little about the aging process, leaving some older exercisers to feel excluded. Initial training to work with older exercisers only focuses on a subset of the older population, and more specialized training is needed to work with people who are frail, or people who are diagnosed with one or more chronic conditions. Such training is not required by many employers, including for those who teach seniors fitness, and they might not have that specialized training. Some ageist practices in the fitness industry also create problems for older exercisers. For example, some instructors are trained to avoid certain movements with older exercisers. One such move is a spinal rotation stretch, which is not recommended for older people with osteoporosis. A spinal rotation stretch, however, is great for people with Parkinson's disease as they suffer from trunk rigidity. Instructors who were competent in these nuances would teach exercisers, if you have X, then do Y. If you have A, then don't do B. This approach, as opposed to avoiding certain movements altogether, is recommended by some agencies, ensure that exercisers know what is safe and not safe for them to perform not only in that particular exercise class, but in all of their other classes and in their activities of daily living. Finally, instructors who can relate to older people, not only by understanding what it might feel like to exercise in an older body, but also can relate to them by playing the music they like in the exercise class or integrating choreography that older people grew up enjoying. Hey, let's do the twist. Create much more inclusive and enjoyable exercise classes where a large number of older exercisers attend on a regular basis. So if we want to increase the number of older people who attend group exercise classes, we need to do more to make them appealing to older people's interests. Let's have more of the people walk out of class saying, that was the best class ever. What else does that instructor teach?
Thank you, Kelsey. And our last presenter in the PhD category is Maram Khalid, and her work on preoperative and postoperative cognitive trajectories in older patients with deferred surgery due to COVID-19 emergency, the COTEL Surge, a prospective cohort study. Whenever you are ready.
COVID-19 has impacted the lives of our elderly population in so many ways. From fear of getting the infection, to changes in their daily activities by the social distancing, to deprivation of their positive stimuli, to deferral and cancellation of many of the health services, especially surgery. All these cause stresses that can affect their lives in general and their cognitive function in specific. So what is cognition? Cognition is the way that we think, process information, make our memories. And surgery itself has been shown to be associated with some cognitive impairment postoperatively in the elderly. But we don't know whether this is a direct effect of the surgery or if this is a continuation of a preoperative trend, especially in this population who have so multiple comorbidities and are on many medications. And this is because all the previous research has been done to assess only one cognitive assessment before surgery and then compare it to one or more afterwards. Hi, I am Maram, and I am presenting the co-tele search. The co-tele search is a prospective cohort study that we are conducting to capitalize on the unfortunate longer than usual wait time for surgery during the COVID-19 era. And we're doing multiple cognitive assessments preoperatively, so we can compare preoperative and postoperative cognitive trajectories. And we're also assessing trajectories of pain, mood, and physical function. And we're doing some associations between these functions and cognition. We are hoping to show that even if there is some sort of decline prior to surgery, that this decline will change or the trajectory will change after surgery. Co-tele search is maybe a preliminary study. It's hopefully it's will be conducted in multi-center, but we're hoping that it will shed some light on the effect of surgery on cognition in general. Thank you.
Thank you very much. So we're now going to move into the postdoctoral fellow presenter category. So at this time, if you would like to place your vote for the PhD, you can fill that out on your form. Just a quick note, there are multiple links in the chat, but they all lead you to the same form. So feel free to use whichever link is closest to you. So leading the way in the postdoctoral category is Dr. Patricia Houston and her work on Can Dance Improve Gait in Older Adults? Whenever you're ready, Dr. Houston.
Thank you. Whether you enjoy watching Dancing with the Stars or dancing in your car, dance is embedded in our lives in one way or another. But dance is not only entertaining and fun, it's a great way to keep your mind and body healthy. My postdoctoral research is focused on dance and how it can improve the health of older adults in our community. There are three main areas to my research: design, evaluation, and dissemination. So the first stop was design, to start to frame my research questions. I conducted 2 systematic reviews and meta-analyses, one on dance in the mind and one on dance in the body. The results were promising, showing that dance improves the way we think and the way we move. But moving outside of the research literature, when reviewing existing programs nationally and internationally, there's very few options for those with early memory or mobility problems. Working as a team, we want to change that and search for creative solutions to make dance accessible for all older adults. As the GERAS Dance scientific curriculum lead, I led the design thinking process, working with an interdisciplinary team of geriatric medicine and rehabilitation experts to understand the clinical benefits. I also work with our YMCA partners to understand what makes a successful seniors program. And most importantly, ask seniors themselves what matters most in a program. Blending all this information together, I developed the 12-week GERAS Dance curriculum. So our next step was evaluation, to evaluate this newly designed GERAS Dance program. Working as a team, we expanded the program to 12 YMCAs across Southern Ontario. We conducted lab-based experiments in 350 older adults. As a postdoc, my work was focused on walking patterns. Using the technology pictured in the slide in the very middle, my study concluded that 12 weeks of GERAS Dance improves walking speed, rhythmicity, and coordination. But beyond the benefits of falls prevention, older adults in the program also wanted to keep on dancing because they enjoyed it so much. So that we moved on to dissemination, building upon the success of the program and learning from experts from the McMaster University Health Ventures program and also Harvard Business School Online. I work to scale our health innovation from an idea to commercialization by creating an online instructor program to standardize training for all instructors. And in the picture here is one of our filming sessions where we had videos of all of our dances. This program is going to be launched across Canada. And also with current COVID restrictions on in-person exercise programs, I am adapting for online delivery to help brighten the spirit, sharpen the mind, and strengthen the body of seniors in our community, one step at a time. Thank you.
Thank you. Next, we have Dr. Ali Reza Shahin and his work on in vitro study of the effect of exercise on brain health in the elderly, breaking complex systems of human physiology to its basic elements. Whenever you're ready, Dr. Shahin.
Thank you. So human body is the most complicated biological system that exists. That level of complexity has made it capable of performing tasks and functions that no other living creature is capable of, but at the same time, it has made it very difficult and sometimes impossible for us to understand how different mechanisms in human body work. As a result of that, there are many diseases that we can't prevent from happening, or once they happen, unfortunately, we can't cure them, like neurodegenerative diseases. There are also a lot of uncertainties around these diseases. Like, for example, there is evidence that physical activity can help with such diseases, but unfortunately, there is no consensus on what type of exercise should be done and for how long. Here is where my project comes in. We are trying to figure out what type of tissues or which tissues are most active during exercise and show a neuroprotective effect. We want to make models of these tissues in the lab, which we call them in vitro models. And once we have such models, we can actually mimic the effect of exercise on them separately. Then we can put them all together in culture or create a multicultural system to understand how human body works in general as a whole. And when we have that a better understanding of mechanisms that are involved in human body, we can understand how exercise works, what type of exercise should be done. And in case someone can't perform these kind of activities, we can find small molecules and drugs that create the same effect as exercise on different tissues. Hopefully, at some point in near future, we will be able to use these models to cure these diseases, prevent them from happening, and even better, at some point, we will be able to find cures for different diseases. And by using these models as part of our discovery process, instead of animal models and clinical trials, we can even decrease the cost of treatment for many of the diseases that exist, and even find cures for diseases that are considered to be uncurable at this time. So let's hope for that day, and thank you, everyone.
Thank you very much. Next up, we have Dr. Tatiana Ribeiro and her work on accelerating the aging trajectory through prenatal adversity. And when you're ready, Doctor.
Thank you for introduction, Cassandra. First, I would like to drive everybody's attention for the pictures on the top right corner of my screen. These pictures bring me a mix of feelings. The small hands here represent the hope in the future, with the new life that only is starting. And also the old hands represents the gratitude for the past, for all that has been done to making the world a better place to live. So this picture is the perfect representation of the past, present, and future together. Nowadays, we have enough knowledge to know that health or unhealthy aging is starting to be shaped during pregnancy and in the first days of life. Dr. David Barker was the first one telling us about the fetal programming. Fetal program is a process that involving intrauterine diversity that can cause long-lasting consequences later in life. These consequences could be diabetes, cardiovascular disease, cancer, or susceptibility to infection, as the new studies have shown. Having pneumonia infection in mid to late life is associated with the risk to develop metabolic disorder and dementia. over 8% of older adults hospitalized for pneumonia infection die early than expected, and 30% develop dementia or becoming cognitively impaired. These studies use the animal model to investigate the impact of obesogenic diet during pregnancy, increasing susceptibility to infection to predispose to unhealthy aging. Our first finds show that maternal obesity increased susceptibility to lung infection in neonatal and adult offspring, as you can see here on the graphics when you compare white and pink bars. This research will help to understand the biological mechanism of disease of aging and help the older adults in their aspirations to live the long and healthy lives. Thank you for attention.
Thank you very much. Dr. Divya Joshi is our next presenter on her work of biological embedding of adverse childhood experiences among 45 to 85-year-old individuals, a cross-sectional analysis of the CLSA. When you're ready, Dr. Joshi.
I'll start by sharing a story of Sophie. She's a 10-year-old girl living in Hamilton. Sophie is neglected by her parents. She's often left by herself and feels lonely. Her parents abuse drugs, and so on most days, they wouldn't even notice whether Sophie's had her meals or whether she's gone to school or not. Upon confronting her parents, Sophie is verbally and physically abused. Let's fast forward some 40 years or so. Sophie is now 50 years old, and she's diagnosed with hypertension, diabetes, and heart disease. She blames her poor diet and inactive lifestyle, but never considers the possibility that her childhood adversity may have contributed to her poor health. This is because stressful and traumatic experiences stay with us forever and change the way we experience events in the future. Health outcomes are a result of multiple exposures during our life course, and these exposures get under our skin and lead to changes in our biological processes, a concept known as biological embodiment. But what we do not know yet is, how do these adverse childhood experiences get under the skin and influence health outcomes throughout the life course? Using data on 30,000 adults from the comprehensive component of the Canadian Longitudinal Study on Aging, we examined two mechanisms through which childhood adversity impacts multimorbidity, defined as the presence of two or more chronic conditions. The first mechanism is the allostatic load pathway, which is a measure of total physiologic dysfunction as a result of repeated or chronic exposure to stress. We found that exposure to adversity in childhood results in progressive wear and tear on our body. Stress modifies the operating balance and causes enduring changes in the nervous, endocrine, and immune systems. And it is this progressive wear and tear of our biologic systems that in turn leads to multimorbidity. The second mechanism is a social engagement pathway. Our findings showed that participating in community-related activities and having stronger social networks and emotional support, having assistance, information, guidance, and feedback, and having personal appraisal support and companionship in adulthood mitigate the impact of childhood adversity on multimorbidity. Overall, adverse experiences in childhood influence health outcomes in adulthood. Therefore, early public health interventions are important to prevent childhood adversity and reduce its long-lasting negative consequences. Understanding these mechanisms is also important to identify individuals who may be at risk for developing multimorbidity, as well as to help lower the social, economic, and health burden of multimorbidity. I'd like to thank and acknowledge my co-authors, Drs. Leslie Atkinson, Parminder Raina, Lauren Griffith, Harriet McMillan, and Andrea Gonzalez.
Thank you very much. Our next presenter is Dr. Fatima Jizendeh, and she'll be looking at enhancing quality of life for older adults with end-stage knee osteoarthritis through patients' phenotyping to tailor the clinical management. And when you're ready.
Yeah, thank you for the introduction. knee osteoarthritis is one of the most common chronic diseases that's affecting the mobility and quality of life in older adults. This represents a significant social, health, and financial burden. And it is estimated that more than 10 million Canadians will have osteoarthritis by the year 2040. The end-stage treatment for this disease is total knee arthroplasty surgery. However, a high number of patients, up to 30%, continue to have significant pain and disability after the surgery. It is interesting to know that patients with the end-stage knee osteoarthritis represent a heterogeneous group of individuals in terms of socio-demographic, pain, joint morphology, and physical activities. But despite the significant variability, clinical management lacks evidence on how to incorporate patient-specific factors into decision-making. And this contributes considerably into the variability of the quality of life before and after the surgery. Also, with the aging population, surgery demand is growing in Canada, which has created a lengthy wait time for the surgery. And obviously, many of the symptoms and variability of the patients changes during this lengthy time, which again is not considered in the clinical management of these patients. So in my research, we want to investigate the effect of patients' variability. We also want to see how these variables changes during the wait time for the surgery and how this might affect the surgery outcomes. This procedure is called phenotyping. Clinically useful phenotyping requires a comprehensive longitudinal approach. Hence, we are performing a prospective cohort study. So, the patients will be recruited at the time of the decision for the surgery up to hospital sites. So, and then the patients will get checked at different time points of decision for the surgery, couple of weeks before the surgery, and 2 time points of 3 months and 12 months after the surgery. What are the variables we are interested in checking them? So we are interested in measuring the patient's physical activity through wearable sensors, measuring the pain through questionnaires, and also measuring the patient's pain threshold, and then measuring the activity restriction through gait analysis, and finally measuring joint morphology and osteoarthritis severity through image processing of the knee x-rays. Ultimately, by doing this research and understanding how these aspects of health changes over time before and after surgery, this will guide us in developing ways to improve quality of life for the knee osteoarthritis patients. And also, it will help us to manage osteoarthritis symptoms based on individual patients' unique circumstances. At the end, I want to thank MIRA for supporting us and funding this research.
Thank you very much. Our next presenter is Dr. Leah Ravensbergen, and her work on mobility work, older adults, experiences using public transportation.
Thanks.
When you're ready.
So a key component of optimal aging is mobility. Mobility is a basic human need associated with independence, health, and well-being. Older adults need to remain mobile to meet their daily travel needs and to participate in social life. So while mobility is clearly important, previous research has found that it declines with age. Older adults rely primarily on cars to meet their daily travel needs, but not everyone has access to a car. This is true for people of all ages, but more common amongst older adults. This is because as health problems arise, many older adults must either reduce their driving or give up the keys. So how do we maintain independent mobility amongst older adult populations? Well, public transit has been put forward as a potential solution. Ideally, what we'd like to see is the picture on the right, happy seniors traveling independently and easily using public transportation. However, very little is known about older adults' experiences using these modes. So my research asks, what work do older adults need to do to meet their daily travel needs using public transportation? Okay, let me tell you a story. This is the story of one of my research participants, who I'm going to call Bob. Bob is 79, uses a walker as a mobility aid, and lives in downtown Hamilton. He gave up his driver's license in 2016. The bus is now his primary mode of transportation. Before COVID-19, he traveled on the bus nearly every single day. Bob's experience using the bus, though, is different than mine. Firstly, Bob has to plan a lot more than I do. To get to the bus, he has to consider the weather because, in his words, the sidewalks that are not shoveled are a real problem with my walker. When the weather is bad, many of my research participants simply stayed home, wouldn't leave their house. Getting onto and off of the bus is also a challenge for Bob, because that lift that might feel small for us is actually quite hard for him with his walker. He also worries about annoying passengers because it takes him a lot of time to board. He's quite slow. Once Bob is on the bus, he needs a seat because he cannot stand while the bus is in motion. However, he's embarrassed about asking for a seat, and he can't sit at the back of the bus where there's more free seats because that would require climbing 2 steps to get back there. Bob also always exits from the front of the bus, even though he knows he's meant to get off using the back doors. Here he knows the bus can lower, which can help him disembark with his walker. Finally, if the walk from his bus stop to his final destination is too far, Bob simply doesn't travel. These are the things that Bob has to do, plan for, or worry about. This is what I call mobility work. This work is pictured on the left of my slide, be it walking through the snow with a walker, taking a big step onto the bus, or not being able to access the back of the bus. Able-bodied passengers don't have to do this work. This is an added burden that those experiencing declining ability, in this case older adults, can experience when accessing public transportation. This demonstrates the ableist logic embedded in transportation planning. In other words, we want the picture on the right, but we forget about all the barriers on the left. Taken together, my research highlights concrete things that transit agencies can do to minimize this work or to make it easier for Bob and other older adults to travel using the city bus. Thanks.
Thank you. Our last presenter in the postdoc category is Dr. Julie Reed and her work on screening assessments for fall risk in older Canadians. When you're ready.
Thanks, Cassandra. Did you know that every year in Canada, 1 in 3 adults over the age of 65 will experience at least one fall? In fact, statistics suggest that an older adult experiences a fall every 12 seconds. That's 15 falls among older Canadians just in the span of this short 3-minute presentation. Hi everyone, I'm Julie Reed, a postdoctoral fellow in the School of Rehabilitation Science, and I'm looking at screening assessments for fall risk in older Canadians. Falls are the leading cause of injury among older Canadians and cost the healthcare system $3.3 billion annually. Falls account for more than half of all injury-related hospitalizations in Canada and 85% of injury-related hospitalizations among older adults. On average, seniors admitted to hospital after a fall will stay in hospital 10 days longer than for any other cause. And unfortunately, more than 1/3 of older adults will not go home, but will be admitted to long-term care. The consequences of falls extend beyond hospitalizations and can result in loss of independence, decreased confidence, reduced mobility, pain, and even death. While there are a number of identified risk factors for falls, with appropriate detection and intervention, falls are preventable. Measures of balance and mobility are most commonly used to assess fall risk. However, we do not know which tests are easiest for older adults to complete and which tests give us the most accurate information. In addition, research suggests an important association between frailty and falls, but we don't know if screening for frailty might help to identify adults at risk for falls. Therefore, the aim of our work is to determine the best measures of mobility, balance, and frailty that can accurately screen for fall risk. Given that we are in this challenging situation with the global pandemic and with older adults being at higher risk for severe illness and complications from COVID-19, we will also be conducting a sub-study to evaluate the feasibility and measurement properties of administering these measures of balance, mobility, and frailty virtually. With physical distancing guidelines in place and social isolation, early evidence is showing that older adults are at even higher risk and experiencing more falls than pre-pandemic. Therefore, it's critical that we not only determine the most effective and efficient measures to assess fall risk, but also that we evaluate ways we can do that safely and while protecting vulnerable populations. Results of this work will be able to inform clinical practice and guidelines on the best screening assessments for frailty and falls risk. Determining an efficient, effective, and safe way to screen falls risk may facilitate early intervention to moderate the clinical course of frailty and prevent falls. Thanks.
Thank you. Sorry, clicked before I finished. Thank you everyone who's presented today. At this point, if you haven't already, please use the link in the chat box to go ahead and vote for each of the 5 categories in total. And we will calculate that up and let you know who the winners are in a minute or two. While that's happening, I would like to give a huge round of applause to all the presenters from undergrad to postdoc. Thank you so much for sharing your research with us today. It's wonderful to see all the different work being done across the university. We'd also like to give a huge thank you to MIRA for providing us not only with the prizes for today to give our award winners, but also for supporting the trainee network in not only putting this event together, but providing us support in helping us build a community for trainees to share, grow, and collaborate. None of this would be possible without you. I change the slide. At this time, I'd also like to thank all the wonderful people who made this event possible. The MIRA Trainee Network Exec Committee is full of wonderful trainees who put a lot of work into making this virtual event happen. Another huge thank you to the MIRA staff, JSING, Allison O, Allison W, and Kara for helping support us through this and navigating through the process of creating a successful online event. This event wouldn't have been possible without all of you. Finally, I want to give a huge thanks to everyone who attended today. It's wonderful to see all the support we have for our trainees and the research they're doing. If you're interested in joining the trainee network, we will provide a link in the chat eventually, but you can also go to the program that we provided in the email this morning to find out a little bit more about the trainee network. We have monthly meetings where you have another opportunity to present your work that's in progress and you have questions, or to practice for presentations. Our next meeting is on November 27th. Our meetings are the last Friday of every month. So we're gonna wait a couple more minutes and then I'm gonna hand the mic over to Brad, who's going to let us know who our winners are for each category.
All right, thanks for that, Cassandra. I had told everyone here that I would close the poll at 10:24. So as I said, in case anyone's finishing up, I'll give that the last 30 seconds there. But yeah, just to echo what many of the comments are saying, fantastic job by all presenters. So it was wonderful. And we hope that coming from this, you learned a little bit about other research on campus, but also that you'd maybe pick up some future collaborations, people you'd like to work with, or even just have a discussion with about their work. So with that said, it's 10:24. We can start going through these responses, the results. So the award for best presentation in the undergraduate division, it was very close, and just edging out, we have Kevin Day. So congratulations, Kevin. Moving on to the best presentation for the master's division, we have Michelle May, who's a project with a secondary analysis of shared risk factors affecting osteoarthritis, cardiovascular disease, aging, and mobility. Moving on to the PhD division, our best presentation was Vanessa DeRubis, Understanding Adversity and Obesity Throughout the Life Course. Congratulations, Vanessa. And lastly, for our best presentation in the postdoctoral fellow division, we have Leah Ravensbergen, Mobility Work, Older Adults, Experiences Using Public Transportation. Congratulations, Dr. Ravensbergen. And lastly, the award for the best 3MT slide. This was very close, a lot of great slides, but ultimately we had Michelle May, Secondary Analysis of Shared Risk Factors Affecting Osteoarthritis, Cardiovascular Disease, Aging, and Mobility. Congratulations, Michelle. And thank you again to all of the presenters for their hard work putting together such a great presentation. We really enjoyed hearing such a diverse range of work and look forward to everything that's going to come from it here at MIRA.
Okay, thank you everyone for attending today. We hope you have a wonderful weekend and we'll see you all in the future. Take care.